Good evening, everybody. I'm going to talk on a relatively newer type of tear of meniscus, which is the ramp tear. Ramp lesion are the meniscocapsular tear of meniscus, which usually is in the posteromedial aspect of the medial meniscus. Ramp lesion, the incidence varies from literature to literature, which ranges between 10% to 40%. I feel that most of these ramp tears are underreported as going into the posteromedial compartment and debriding and probing the ramp area is not very commonly done by many of the surgeons. And on top of that, a certain part of these ramp lesions are hidden lesions, especially if it is in the undersurface of the meniscus. If the tear is in the inferior part of the meniscotibial junction and there is a healing on the superior part, these may not be visible. That is why there is a possibility of missing this lesion, and according to various literature, which ranges between 40% to 60%. That is why a very systematic approach for the diagnosis of ramp lesion is very, very necessary. If someone who is having a high grade pivot shift test, a ramp lesion has to be suspected, and when you do arthroscopy in this patient, you have to go into the posteromedial compartment and try to probe the ramp. If someone is having excessive anterior translation, like grade 3 anterior drawer test, is very, very important to go into the posteromedial compartment. There was a consensus that these ramp lesions are very common in the chronic ACL group. However, there are a lot of study which is saying that it is equally present in the acute ACL tear. That is why it should not be taken for granted that in acute case ramp will not be present. If it is a chronic, especially when the patient has a multiple episodes of instability, these are the cases in which ramp lesion is a very high possibility. The second question is, which of these are the most valuable diagnostic tool for ramp lesion? A detailed clinical examination is very, very important to identify what is the degree of anterior translation, what is the pivot shift test, and there are some new tests coming up to describe the ramp lesion. Uh, in MRI, looking for a tear in the ramp area may not be a very good idea, although the sensitivity may reach up to right up to 80%. There is a high possibility in our part of the world where these tears are missed in MRI. Secondary signs are important in usually in case of acute tear, especially the bone bruises and the bone edema in the posteromedial edge of the tibial plateau is very, very important. But what is the most important for diagnosis of the ramp lesion is a high degree of suspicion and visualization of the posteromedial corner. There are various ways of visualization of the posteromedial corner of the meniscus. Most commonly done is the Gilchrist maneuver, which is also known as the intercondylar approach, in which from anteriorly beneath the PCL, you go into the posteromedial compartment and look at the posteromedial part. And this has been shown that it can be done using a 30-degree scope. That Bernard said that 30-degree scope is good enough. However, Kim said that probably a 70-degree scope will give us all the corner visibility. Most of these authors, they agree that whenever in doubt, probably we have to go into the posteromedial compartment through a posteromedial approach and try to probe it whenever necessary, debride the superficial part to reveal the hidden ramp lesion. As far as the repair is concerned, there are various ways of repairing it, like meniscal repair. There are outside in technique described. The inside out technique has also been described and very popularly used by many of the surgeons. All inside is my best technique, is my preferred technique. And amongst the all inside, there are two various types. Like one is the suture anchor based repair of the ramp lesion. I do not do a suture anchor repair of the ramp lesion. My favorite technique is using a lasso loop, also known as the suture hook technique, which is I'm going to demonstrate here. This was a patient left knee of a 23-year-old gentleman, was a male weekend footballer, sustained knee injury 14 months back, visited multiple places, and when he came to us, he came with MRI, in which you can see that there was a ramp tear along with some other component, the component of the complex tear. So here you can see that is the RAM component of the tear in the sagittal section. This is the RAM tear I was talking about. And if you go on the coronal section, you can see that there is a component of a radial tear. And in this section, you can see that there is an overlapping of the meniscus, which shows the flap component of the meniscus. So this patient had a ramp tear, a radial tear with the flap tear. And on the sagittal view, you could see that the ACL was torn. Clinically, examination under anesthesia, this patient still had effusion. Uh, there is a grade 3 Lachman test positive. The anterior drawer test is also positive, which is about grade 3, and there is a no hard endpoint. Uh, Note that the patient had a grade 3 pivot shift test. This is the arthroscopy view, in which you can see that this was a chronic ACL tear. The lateral compartment was normal. The medial compartment was little tight, so I did a pie crusting to expose adequately the medial meniscus. And this is unprobing of the medial meniscus, where you can see the radial component as well as the flap component, which mentions that this was a complex tear of the medial meniscus. Then we went into the posterior medial compartment by doing a modified Gilchrist maneuver, and the ramp lesion on the posterior medial compartment was quite obvious. You can see that this is the meniscus, underneath is the tibial plateau. This is the tibial plateau, and this is the meniscofemoral ligament, and this is the classical ramp lesion. So we made a single posteromedial portal. In this case, the posteromedial portal was made for ease of passing the sutures. The cannula was placed. I use a diamond rasp, and sometimes I use a low suction shaver to clean, if especially it is a chronic case, to clean and freshen the edges. Then a specific lasso loop wire passer is taken. First, we take into the capsular part and then into the meniscal component, and the proline is passed through the loop. Then the proline is used to railroad the ultra braid suture, and then a sliding knot is tied. The type of knot tying, either to use a sliding knot or half hitches, depends upon the quality of the suture. In this case, the quality of the meniscus. In this case, the quality of the meniscus was good, so we decided to put a sliding knot. Again, taking both the ramp part and the meniscus part. What I do usually is I keep the tails of the knot intact until unless I apply a second knot, so that I can pull it and stabilize the ramp side. So here the second suture is being passed. Another additional half hitches has been thrown. And then I keep this suture intact. You see here, the suture are intact. Then I use I use the same lasso loop, take a bite into the ramp part, and then into the meniscus part. And you can see that the suture is still intact, and then I have still pulling it so that I can stabilize. So once both the limbs are out, I cut the suture, the ultra braid, and then use the proline suture to shuttle or to railroad the ultra braid suture and apply the third knot. So once it is tightened, another few half hitches has been added to that, and then this completes the repair. So once the knot has been applied, you cut the suture and the repair has been complete. So by using probe, you can see that this is a nice and tight repair. So this is the pre-operative ramp tear, and this is the post-operative in which you can see that the ramp tear has been repaired. The patient did clinically well, had a injury on the other side. So the patient, when presented for doing MRI on one side, we decided to do an MRI of the other side as well. And you can see that the ramp lesion at 1 week follow-up, this has healed. So to conclude my presentation, ramp lesion are very common. The incidence ranges between 20 to 40%, but usually these are missed. That is why a meticulous examination of posteromedial compartment is necessary to reveal the hidden lesion. And ramp repairs have good healing rate. Thank you very much.